Hi, this is Dr. Nicholas Hatcher, and welcome to this lecture on acute respiratory distress syndrome. The objectives of this lecture are as follows. Number 1, recall the common causes of ARDS. Number 2, understand the pathophysiology of ARDS. Number 3, apply the pathophysiology of ARDS to clinical recognition and management. Number 4, differentiate the phases of ARDS. Number 5, recognize the ARDS manifestations. And number 6, apply pharmacologic and non-pharmacologic principles of management to the patient experiencing ARDS. In order to understand the management of ARDS, it's important to first review mechanical ventilation, as this is a key component of ARDS management. Acute respiratory distress syndrome is defined as an acute hypoxemic respiratory failure characterized by the accumulation of protein-rich fluid in the bilateral lungs due to a systemic or pulmonary injury. The terminology used for this disorder has evolved over time. Originally, ARDS was referred to as double pneumonia. Then, for a period of time, it was referred to as post-traumatic massive pulmonary collapse around the time of World War I. Then the term changed to traumatic wet lung around the time of World War II. Just prior to being referred to as ARDS, it was referred to as shock lung, as the association between this syndrome and shock became more recognized. The incidence of ARDS is approximately 190,000 cases per year and increases with age. I provided some incidences for comparison here to show how ARDS compares to other conditions. ARDS has a mortality rate of 40 to 50%, with roughly 74,000 deaths per year. Increased mortality is found in African American males, advanced age, shock on admission, immunosuppression, and coincidentally, obesity is protective. The causes of ARDS are displayed here. Pneumonia is the cause in 35% of cases, severe sepsis in 26% of cases, aspiration in 15%, trauma in 11%, and other causes account for 14% of ARDS. These other causes include drowning, pancreatitis, reperfusion injury, occurring in myocardial infarction, salicylate or narcotic overdose, fat or amniotic fluid embolism, smoke or chemical inhalation, and transfusion-related acute lung injury. Most patients suffering from ARDS do not die of underlying respiratory disease. Rather, multiple organ dysfunction syndrome, or MODS, is the number one cause of death, which accounts for 65% of deaths. Respiratory failure alone accounts for 25% of deaths. And finally, the underlying injury or illness accounts for 10% of deaths. Here I've provided a brief visual review of the relevant anatomy that we will need to understand in order to conceptualize ARDS. We will discuss physiologic principles in the following slides. Please take a moment to orient yourself to the relevant alveolar anatomy. There are two main types of pulmonary cells, type 1 and type 2 pneumocytes. Type 1 pneumocytes make up 90 to 95% of the alveolar surface. They are squamous or flattened in nature and thin, about 0.15 microns. They are involved in gas exchange and are amitotic and unable to replicate. Type 2 pneumocytes, on the other hand, account for 5 to 10% of the alveolar surface. They are granular and roughly cuboidal in structure and store surfactant. They additionally secrete surfactant. Type 2 pneumocytes are able to differentiate into type 1 pneumocytes. Let's review normal fluid movement around the alveolus. Overall, deoxygenated blood enters the capillary and leaves oxygenated through the process of alveolar gas exchange. Through this process, excess fluid is drained into the interstitium and picked up by the lymphatic circulation, or returns to the capillary. This is a normal process as the capillary membrane is fenestrated, allowing for better mobility of substances across the alveolo-capillary membrane. A balance is maintained here by the Starling forces. This refers to osmotic pressure, or the pushing force, and oncotic pressure, or the pulling force, to prevent excessive fluid accumulation in the interstitium. This will therefore prevent a widening of the interstitium, which is important because gases such as oxygen and carbon dioxide cannot travel very far. ARDS occurs in 4 phases. These phases are sequential and listed here. We will go into each of these phases in more detail. In the exudative phase, the hallmark characteristic is that the macrophage recognizes an antigen or cytokine. Antigens are foreign bodies, and cytokines are inflammatory byproducts. This process can be initiated by 2 pathways, the alveolar pathway and/or the endothelial pathway. In the alveolar pathway, an airway antigen binds to the macrophage receptor, and the macrophage is consequently activated. In the endothelial pathway, an endothelial antigen or cytokine binds to the endothelial receptor. Ultimately, this migrates up to the alveolar macrophage and activates it, but you will see more of this activity in the following slides. Here I've listed some examples of conditions that activate the alveolar and endothelial pathways. Once the macrophage is activated, it releases factors to recruit neutrophils. I provided a little more detail here as to which inflammatory factors are released and their specific function, but the take-home message here is that the activated macrophage recruits neutrophils. Once neutrophils are recruited and activated, they release a variety of products into the alveolus and alveolo-capillary membrane, including leukotrienes, oxidants, and proteases. Cytokines ultimately leak into the alveolo-capillary membrane and bind to endothelial receptors. The release of these products results in the changes we will discuss on the next slide. First, there is a breakdown of the bronchial epithelium. This contributes to a weakening of the integrity of the epithelial structure. Second, there's destruction of type 1 and type 2 pneumocytes, contributing to loss of related functions. Third, there's development of a thickened hyaline membrane. Fourth, there is accumulation of cellular debris in the alveolus. The development of a thickened hyaline membrane and the accumulation of cellular debris contribute to endothelial gap formation. Remember, as I alluded to earlier, that there's a specific distance maintained between alveolus and capillary. This specific distance is required for oxygen and carbon dioxide to move between the alveolus and capillary. Injury to type 2 pneumocytes results in decreased surfactant production and deactivation of surfactant. Like jello, fluid mixed with protein results in accumulation of thick, protein-rich fluid in the alveolus. Fluid accumulation in the interstitium overwhelms lymphatic circulation and results in a widened gap between the alveolus and capillary. The underlying mechanism of hypoxemia in the patient with ARDS is shunting. Basically, there is perfusion or blood flow without ventilation or oxygen-carbon dioxide exchange. As shown in this image, conceptually there is a blockage on the airway side as opposed to the vascular side. When shunting is widespread, the result is detrimental hypoxemia. This makes sense because if we attempt to put this patient on 100% oxygen, it will still have difficulty navigating to the bloodstream in order to maintain oxygenated circulation. If we look at the opposite side, dead space, you'll see that the problem lies on the vascular side as opposed to the airway. For comparison, an example of dead space is pulmonary embolus. As the exudative phase progresses, homeostasis becomes significantly deranged. In an attempt to heal, fibrin is deposited, and platelets begin to accumulate at the sites of endothelial injury. This may assist in the healing process, but also increases the risk for disseminated intravascular coagulopathy. Now let's look at the proliferative phase. In this phase, fibroblasts accumulate, which synthesize and secrete type 1 and type 2 collagen. These are like the scaffolding substances of cells that maintain cell structure. The goal of this phase is to restore alveolar integrity. Type 2 pneumocytes also proliferate in preparation for differentiation into type 1 pneumocytes. Overall, the goal of the proliferative phase is to heal and restore the alveolus. In the fibrotic phase, fibroblasts continue to accumulate, and there is further deposition of type 1 and type 2 collagen. Sometimes, this becomes excessive, resulting in extensive pulmonary fibrosis and a loss of alveolar architecture, described pathologically as architectural distortion. In the resolution phase, there is essentially a gradual reversal of all of the damage done. There's repopulation of bronchial epithelium, apoptosis, and phagocytosis of neutrophils occurs. Phagocytosis, diffusion, and endocytosis of proteins occur. There is a reabsorption of alveolar fluid. There is a proliferation and differentiation of type 2 pneumocytes. And finally, there's a gradual resolution of fibrosis. The manifestations of ARDS include the following. There is respiratory distress that presents in the form of restlessness, dyspnea, tachypnea, and accessory muscle use. There is hypoxemic respiratory failure with compensatory respiratory alkalosis. There is refractory hypoxemia with minimal to no increase in oxygen saturation with oxygen administration. As you will recall, this is due to shunting. There is pulmonary edema with alveolar collapse, noticeable on exam through diminished breath sounds with or without crackles. If the patient is already on the ventilator, there will be an increase in the peak inspiratory pressure on the ventilator as a result of pulmonary congestion and high airway resistance. Finally, there are increased pulmonary artery pressures or pulmonary hypertension, and this is because when the lungs become hypoxemic, the vessels vasoconstrict so you can deliver more oxygen to other organs. For a diagnosis of ARDS, one of the most common sets of criteria is the Berlin definition. According to the Berlin definition, symptoms must occur within 1 week of known insult or worsening respiratory symptoms. On imaging, there are bilateral opacities not explained by effusion, lobar or lung collapse, or nodules. The origin of pulmonary edema is not explained by cardiac failure or fluid volume overload, abbreviated FVO, and the PaO2 to FiO2 ratio on days 3 to 7 defines severity. This criteria must be met with a PEEP at minimum 5 centimeters water because PEEP can affect the PaO2 to FiO2 ratio. So you can appreciate the widespread damage of ARDS and how it compares to other conditions, let's look at some imaging. This chest X-ray was done on a patient with cardiogenic pulmonary edema. The difference between the pulmonary edema of ARDS and the pulmonary edema of cardiac origin is the makeup of the fluid. In cardiogenic pulmonary edema, the fluid is not filled with cellular debris and proteins, and is therefore less viscous. This makes a patient with cardiogenic pulmonary edema more responsive to diuretics such as bumetidine or furosemide. Cardiogenic pulmonary edema is a result of, as the name suggests, cardiac disease, such as heart failure, valvulopathy, etc. Some defining imaging features suggestive of cardiac etiology of pulmonary edema include a widened vascular pedicle width, central infiltrates, curly B lines, which look like curly fries up close, and cardiomegaly, or an enlarged heart. In contrast, the chest X-ray from a patient with ARDS will reveal what's referred to as bilateral whiteout. These infiltrates are more peripheral, and there is no evidence of cardiomegaly, curly B lines, or a widened vascular pedicle. This is a CT image of a patient in the acute phase of ARDS. I have labeled each area showing where there is a pleural effusion, marginally functional lung tissue, non-functioning lung tissue, and up in the right-hand corner, you will see near normal lung tissue and what this should look like. I like to share this image because it really shows the widespread damage done by ARDS. Here I've provided a differential diagnosis for ARDS. These are other conditions, apart from cardiogenic pulmonary edema that we've discussed, that may look like ARDS. I will not go into detail on this slide, but these are things that the nurse practitioner or physician may look into as potential causes of the patient's presentation. Likewise, as I mentioned while discussing the pathophysiology of ARDS, this condition will likely result in some degree of pulmonary fibrosis. This especially occurs if the condition progresses into the fibrotic phase. However, there are several causes of pulmonary fibrosis that I've listed here. Primarily, these come from a group of conditions referred to as interstitial lung diseases. This is a very complex topic, and for now we will not go into any detail on the various types of interstitial lung diseases. Now let's discuss the management of ARDS. Management of ARDS includes the following: early lung protective mechanical ventilation with a low tidal volume and modest amount of PEEP, aiming for a plateau pressure of less than 30 centimeters of water. Adequate sedation to avoid patient-ventilator desynchrony. Conservative fluid management, which has been shown to decrease ventilator days by 2.5, as well as mortality. Early enteral feeding, with trophic feeds for 6 days, then full feeds. Traditionally, it was recommended to use neuromuscular blockade, for instance through the use of a medication called cisatracurium. This was thought to avoid desynchrony, decrease oxygen consumption, and reduce inflammation. There was a 2019 study that challenged these assumptions and was largely non-supportive. Therefore, based on evidence, it is no longer recommended to use neuromuscular blockade, but we will, however, discuss this as it's still used in practice. Prone positioning for greater than 12 hours per day recruits dependent lung units, which improves oxygenation. Extracorporeal membrane oxygenation, or ECMO, can be used for profound gas exchange abnormalities when ventilation cannot sustain life. It's possible that statins reduce the inflammation seen in ARDS. This is still up for debate in research. Finally, there's largely no improvement with steroids, exogenous surfactant, or short-acting beta-adrenergic agonists or SABAs, which include inhalers like albuterol. There is some conflicting data suggesting that early steroid use may improve the trajectory of ARDS. This is a model used to describe lung protective ventilation. The curve shown here is referred to as the lung hysteresis curve. This curve is influenced by volume and pressure. The goal is to maintain the patient in the middle by adding PEEP and limiting overdistension of the lungs. On the left extreme, there is not enough volume for the increase in pressure. On the far right, there is not enough volume for the increase in pressure because you've overdistended the lung. This is conceptually why low volume and modest PEEP mechanical ventilation is most beneficial for individuals with ARDS. While using sedatives, the bedside nurse will monitor the patient using a sedation scale. The most commonly used scale in practice today is the Richmond Agitation Sedation Scale, abbreviated RASS or RAS. I would encourage you to familiarize yourself with this scale as it is important for monitoring of the ARDS patient receiving sedation. Note that the goal is an RASS or RAS score of 0. The widespread use of neuromuscular blockade in the ARDS population likely stems from the results of the Acute study. In this study, 340 patients with ARDS and a PaO2 to FiO2 ratio of less than 150 were divided into two groups. The treatment group received cisatracurium for 48 hours. The control group received a placebo for 48 hours. In the boxes to the right, I've displayed the 28 and 90-day mortality rate from both groups. The problem with this study is a marginal p-value at 28 days and a p-value showing lack of significance at 90 days. It's important to note that when looking at a research study, a significant p-value is less than 0.05. An additional limitation of this study was the sample size. 340 patients is not quite enough to generalize this intervention to the entire population. In 2019, the ROSE trial by Moss and colleagues was completed. This trial recruited 1,006 patients with ARDS with a PaO2 to FiO2 ratio of less than 150, randomized in the same groups as the Acute study. This study was stopped early due to futility, and the 90-day mortality rate was estimated to be roughly equivalent in the two groups with a p-value of 0.93. This led to a change in the recommendations by the ARDS network so that now neuromuscular blockade is no longer recommended. Because neuromuscular blockade is still commonly used in ARDS, as well as other conditions, now would be a good time to familiarize yourself with Train of 4. Train of 4 is measured using a device similar to a TENS unit to measure muscle twitches while a patient is receiving a neuromuscular blocking agent. This is done to ensure adequate titration of the agent. For the purpose of examination, 2 twitches is the goal. With 4 twitches, you will need more medication, and on the other extreme, an absence of twitches indicates an excess of medication. The PROSEVA trial by Guerin and colleagues is probably one of the best among several studies supporting prone positioning. As you can see here, there is a significant difference in the 28 and 90-day mortality in the group receiving prone positioning. The current standard is to prone the patient for 12 hours per day. This intervention makes sense in that prone positioning offloads pressure from the lungs and recruits more posterior and inferior lung units, which are more involved in perfusion for gas exchange. This slide shows some of the basic mechanics of extracorporeal membrane oxygenation, or ECMO. This procedure is reserved for individuals who fail to maintain oxygenation on optimized mechanical ventilator settings. ECMO involves removing blood from one side, always venous, and returning the blood to the patient, either on the venous or arterial side, after moving through an oxygenation system. There are two types of ECMO. Veno-venous, or VV ECMO, primarily supports lung function. A cannula is placed in one or two large veins. The cannula has two channels allowing for blood draw and return. On the other hand, veno-arterial, or VA ECMO, supports heart and lung function. One cannula is in a large vein to draw, and one cannula is in a large artery to return. This image provides a conceptual model of the oxygenation system used in ECMO. Venous inflow enters a pump, which moves through the oxygenator, which functions much like the alveolo-capillary membrane, allowing for oxygen and carbon dioxide exchange, and is then returned as arterial outflow. A device referred to as a blender mixes air and oxygen as part of the quote-unquote lung portion of the device. This concludes the lecture on ARDS. Here you will find my references. Thank you for watching.